Hi everybody, welcome to episode 3 of the PSS podcast. Today, as usual, I'm joined to my left is Anita Plant.
Good morning, everybody.
And we've got Nikki Johnson.
Good morning.
Gary Flack.
Good morning.
And myself, Sean Fowler. This week, we're going to be talking about a very common condition that affects people with... Thanks, Gary. He's just turning my notes over. Very helpful. We're going to be talking about a very common condition that affects many people. It's cataracts. Gary, could you please explain to us what cataracts are, how they develop, and what the common symptoms that people should look out for?
Okay, yeah, sure. So cataracts, a lot of people think of cataracts as being kind of an object or something that's in your eye, but all it is, it's a change of state of the lens that's in our eye. So the lens is the bit that gives us our focusing, and when we're younger it flexes and we can see close, we can see far. As time goes on, then we find that the lens gets less flexible, but also it gets a little bit cloudier as well. So a little bit like a steamy bathroom window, and that's actually what the cataract is. So the lens, rather than being beautifully cut crystal, actually looks a bit like a steamy bathroom window.
That's great. So, and one of the main risk factors for cataracts is age.
Yeah, absolutely, yeah. So as soon as we're born, our lens being cut crystal, it starts to degrade. It goes slightly yellow to begin with, and then it goes, as I said, to the nice steamy bathroom window effect. It's slow, and therefore we tend not to notice it until there's a point, maybe if one eye is a bit worse than the other, then you kind of suss out that there's a difference in your vision. And it's amazing when people have actually had a cataract done, they're amazed at how different the vision is with the one that they've had done, and they hadn't realised just how the vision had degraded. So yeah, age is a big factor with it. But there are other factors as well.
Yeah, and what's some of those other risk factors?
Okay, so these are risk factors, things, some of the conditions that we can get, things like diabetes, that's certainly more significant. People who develop diabetes develop cataracts much earlier. Smoking's a big risk factor as well, so unfortunately smoking, and we're not sure about vaping at the moment, but I think sort of in the future we may well find that some of the chemicals that are in them, then those actually might be causing problems with cataracts too. Sunlight's a big one, so having sunglasses with a UV 400 which is protecting, that's a good idea. And in fact, I did read some research that said that by the age of 11, around about 20%, 30% of damage to the eye, the lens, had already occurred. So trying to get a sort of an 8-year-old to wear a pair of decent sunglasses is kind of hard work, but that's one of the factors. So when I was younger, outdoors all the time, that would, promote them. But I'm not saying that you shouldn't go out. The other things are things like steroids. So if you have things like rheumatoid arthritis or osteoarthritis, and you've been given a fairly high dose of steroids for any long period of time, that can actually promote cataracts too. But again, it's the sort of benefit of the steroids help you with the condition that they're treating you, but it's a side effect, so it's kind of balancing them up. And at the end of the day, you can remove a cataract. So although you say with the last 3-4 years using steroids, being able to be active and fit, then the cataracts is a secondary element to it, rather than you shouldn't be taking steroids. And the other one, unfortunately, is chemotherapy that knocks 6 bells out of your body anyway, and does promote cataracts. But again, lesser of the two evils, in which case, having that cataract removed is one of the options.
Yeah, well, that's super informative. Well, thank you very much, Gary. So we talked about that steamy window effect. Obviously, that's going to be really disruptive to people's lives. So, Anita, how have you noticed in your years working as a low vision assessment officer, has cataracts affected people's lives?
Yeah, mostly people complain about the colours start to get really dim. They stop noticing the telly looks really dim. The colours on the television, they struggle with that. And also glare is a big issue for people. So that's a major thing. Just the lack of clarity, really. So I mean, if you imagine yourself, if you're trying to look through a dirty window into the room beyond, it's not clear. You can't really see the objects clear. So that's the main sort of functional difficulties with that.
One of the giveaways there, saying that colours go dim, is that my granddad, when he didn't know he had cataracts, he was watching the snooker and I came round and he turned the colour saturation really up.
Absolutely, yeah.
And I was like, what are
Yeah,
you
when I
doing?
used to do home visits many years ago, it's one of the first things, if the TV was on, I'd actually, as I'm walking in, say, hello Edna, and then have a look at the TV, and if the sort of referee's face is glowing bright red, and the red balls are really red.
We kind of know what we're working
I
with.
know
there.
we've got a cataract going on. But for that person, so kind of bright reds to them would look like soft pinks.
Yeah, so driving would
Yeah.
probably, if you're driving, you start to notice that the traffic lights are maybe not quite as clear as they used to. And at night time, if someone's driving, they get...
That's a big one for the night
big one, isn't
driving.
it?
You get
Yeah.
halos around the rear lights in particular, the red lights in particular. So again, you get the starburst effect. But also the lower sun in the morning, and we're recording this in kind of quite hot temperatures at the moment in August. But come to back end of October, the sun's going to be lower in the horizon. So unless you've got decent sunglasses on, you will notice that the light that's coming in gets bounced around, and you end up seeing a lot less.
Also on that, especially kind of if you're thinking about like the winter, like Gary said, the light's really low, but what happens is we might have a frosty day, so you've got the light reflecting back off, like a light surface like frost or snow, or even sort of wet surfaces are going to cause that sort of more discomfort glare in the eye.
The opposite side of that is kind of reading in poor lighting. So if there's not enough light around, the cataract soaks up the light before it gets in there. So we need a lot more light than we started with. So the counter opposite happens when we've got low lighting as well. So quite often when we have people with cataracts, we talk about having a good strong light quite close by. That means between you and what you're trying to read. Often we get people where they've got a standard lamp with a beautiful shade that's pointing to the floor, and all the light's hitting the floor and the ceiling, but not actually onto what they're trying to read. So just bringing an angle lamp, sort of 6-12 inch away from the page, really does help. Makes it, and you're controlling the lighting too. So that's kind of a good tip for if you're struggling at night when you're reading. Yeah,
because that'll increase the contrast as well. The closer it is, the more it will increase the contrast. The other thing as well is, while we're talking about contrast, is because the colours are so saturated, you need to think about bringing in more contrast as well. So you'd be looking, so for example, if you were eating and you had a white plate on a white tablecloth and you've got macaroni cheese, it's a bit of a nightmare really. So again, you'd put that white plate on a dark background, and that would just help see things better. Really, while we're talking about light as well, again, like Gary said about the position of the light, and sometimes just adding extra light in the forms of a head torch can be really useful, because then you're hands-free, and so if you're wanting to do manual tasks, or if you're doing some DIY and stuff like that, just adding extra light can be really helpful.
We're also talking about sort of reading, sort of natural reading, whereas books and lighting. But obviously, you Sean, as the IT expert, how would you get around that for someone? Would you sort of help them with things like Kindles and things?
Yeah, sure. So expert in inverted commas, definitely. But I appreciate the sense.
I did my best.
You're our tech guru. What do you mean?
So a lot of times with devices and stuff, now they come with adaptive brightnesses and stuff, which can be good for reducing glare and stuff, but it can really dim the screen down. It's not really that clever. So turning off adaptive brightnesses on device and whacking that brightness really high up, that'll help bring that up a bit as well, and then just increasing the text as well size. So you can do that so much that it starts disappearing off the screen, and that's not very helpful. It's disruptive to reading. So in the accessibility options of all devices, there should be a magnifier option where you can actually then manually increase and decrease the screen, basically, which is turned off by standard, because again, if you're not in need of it, it's quite disruptive.
Would you suggest making it inverted colours, so instead of having black text on a white background, you'd have a white text on a black background?
Yeah, but in my experience, it tends to be 50-50 what people like. But yeah, in general, inverting colours.
I think it's good trying it, isn't it? Is it just, don't leave it as what it was set. Just see if another version of it would actually help. Yeah.
Absolutely, yeah. So sitting down, because everyone's different with it, I think, but in general, yeah, we think black on yellow is high contrast, don't we?
Sometimes, Gary touched on like sunglasses, wearing good sun protection. So sometimes, in my experience over the years, and this is it's very subjectively individual, but you wearing a yellow filter inside can help to increase the contrast. So for some people within our low vision clinic, if they kind of go like, I've got cataracts and I'm waiting for an operation, I'll kind of go, let's try this yellow filter. And if I put it on, they'll go, oh, that's fantastic, that's lovely, that is, oh, that's, or else I'll put it on and they'll go, no, everything looks yellow. So it's a sort of an instant thing. So it works for some people, it doesn't work for others. But that's it's always worth trying, and it's something that I'll suggest. People get a bit hung up as well on what colour filter should I use, and that, again, that's very subjective. It's just about providing.
Definitely for cataracts, the yellow helps because it reduces. The dark things become darker, and the light things become lighter. So you actually increase contrast, which is in essence what you've lost with the cataracts. So it makes sense that would help. The downside, obviously, any filter in front of your eyes, any tint, is going to reduce the amount of light that goes in anyway. So if you're then using it in a dark room, that might actually not be a good idea. But certainly when you're out and about or when you're indoors watching TV, that definitely helps, yeah.
Can I ask you about the driving glasses? Because I know some people in the old days, they kind of, they were I think it was the RAC used to sort of like, you sell all these like nighttime driving glasses, and I know that's not a good idea now.
I'm 60 now, and my dad had them when I was young. I remember putting them on. For me, it just made things so harsh and bright. I just didn't like it. But the RAC many moons ago actually had them and sold them as nighttime glasses. There are laws around about the depth of tint that you should use for nighttime driving. So if you approach any optician and say, I want a dark tint for driving, they will advise you the depth of tint that you can go to without then not being legal for a start, but also, logically it's going to lead you into bigger problems if you're not seeing as well, which is not the idea of that filter. So the nighttime filters lost their vogue because there were a few accidents at night, and when they looked into it, the people were wearing the yellow filters. So I'm not a big fan of advising yellow filters for driving, even if you're legal for driving, just simply, although it does make the contrast better. If someone's walking out from behind a bus that's actually in the shade or in the shadow, then you won't actually see them before they kind of jump out on you. So I'm not a big fan of that one, I'm afraid. And they've lost their vogue. I have seen them in some of the petrol stations of recent, and ironically on the features that they put on the one I saw a few months ago, it said that it got a UV 400 on it for nighttime driving. So UV 400 is to protect you against UV, which is from the sun, and yet these are for nighttime driving. So I kind of chuckled and shook my head at the same time, thinking, can't believe that they're doing that. But you can imagine the marketing guys saying, what else can we write about it? And that's actually where I saw it. Yeah.
Well, that's a lot to take in, isn't it? And if someone's listening to this and they're worried about cataracts, it's going to be quite a strain, I imagine. But Nikki, as the mental health and wellbeing therapist, can you talk about a little bit of emotional impact that people can expect from developing cataracts and how it affects their self-esteem and confidence?
Yeah, I think the big one here is going to be frustration, so cataracts don't tend to be fast growing, so it's something that somebody will kind of be moving with and working with for quite some time. Sometimes, in the early stages, they're not even told that they have cataracts because they're not at a point where anything would need to be done, but they might still be starting to noticing change in their vision. And that can be really, really tricky because those kind of fine detail things, those things regarding colour and all the other things that sort of Gary and Anita have mentioned are starting to become an issue. But when it comes to sort of perhaps going to the optician or going to see their ophthalmologist, it's not sort of on their radar as something that needs immediate treatment. And that can be really frustrating.
I mean, I kind of see people where you can tell they're worried when they come to see me, just the eye test side of it. So I know they're stressed about it. And actually it's that they do drive, but am I going to tell them they can't drive because of the cataracts? So in fact, that's a hidden one that they've been taken on board, and they eventually come to see me and sit there, and they're really worried about it.
Yeah, and when I used to work in the hospital, lots of people working in healthcare have this way about dealing with conditions sometimes where, you know, to us it's bread and butter, it's things that we might see all day every day, and they're sort of different elements of weight and heaviness to them, but for the patient it's always the worst possible scenario.
Yeah, very much so.
And so they can come into the room sometimes when I used to do, you know, scanning and imagery on people, and they would be absolutely terrified of this cataract that they'd got, sort of not really understanding that, you know, if it's a nice straightforward one, there's no other things to be considered, it's not complex, that actually it can be treated and dealt with quite, you know, safely and quickly. But for them, it's, oh gosh, I've got cataracts and it's, I'm going to lose my vision, I'm never going to get it back, and it's this really kind of big thing. And I think that's where a lot of this comes from, what you're talking about. It's that not really fully understanding that in general cataracts are quite temporary. You know, it's something that can be treated well, you know, has a really high success rate. And trying to sort of get that out there more would be, I think, really helpful for people.
A lot of people ask me like, oh, I've had my cataracts done, you know, but can they grow back? Are they growing back? You know, and it's like, no, once they're out, they're out.
Yeah.
It's an artificial
But
lens.
that's, you know, people don't always understand that.
And that really obvious thing of, you know, when people understand that there's an operation and it's on the eye. I think the minute you say that to somebody, you know, it's
Makes your
you
toes
know,
curl.
it does, it does.
I know, it's the one part of the body where people are really squeamish.
You used to go to technology. Technology is brilliant, but now you can get access to all the information on a
Yeah.
heartbeat. So you instantly go to YouTube
Dr.
and you look in
Google.
details and be like, oh, we're going to scrape my eye
Yeah,
and
you
what?
can even
And
see you can even see videos of them actually doing the cataract job. Which
Absolutely.
taking
So
the
I tend to use the word procedure these days rather than operation, and that's just to help that, you know. I think also, again, if someone comes to me and their one eye's dropped vision-wise and it is the cataract that's causing it, I'm always wary that if they don't know about it, if I say you've got a cataract, I've labelled something, now you have a condition, and that changes all that conversation. So it's important that if you are going to say you have a cataract, is that you say, and this is what it does and this is what we can do about it, because you need to fill the gaps in. And in a natural, normal eye test in kind of a retail opticians that might only have 20 to 25 minutes maybe, and it is difficult to work out whether what I've just told you can deal with. I have come across it, having worked in hospitals where people have, you know, spent 9 months waiting to come and see us, and then, you know, really, really worried, and then you kind of go, it's okay, we can sort it. And it's like, seriously? And they've wound themselves
that 9
up
months of
all,
worry, isn't
nine
it?
months of worry. So there is that factor, but cataracts of the conditions that we get with eyes, it is one of the better ones. Just got to bring in some stats to help out. It is actually the leading cause of blindness in third world. So we talk about Africa, India, places like that. Which I know he's obviously from South Africa, and I want to just bring that in because you may see that if you do Google it, and it's like, you know, the leading cause of blindness, but the important bit is that it's third world for one. And the reason is the cause of blindness is because they don't have the facility to remove that cataract. So cataracts are a temporary blindness, but they won't actually have that facility of going, yep, I'll just send you off to get get that removed. So whereas in England and the UK, that's not an issue. It's way down on the stakes.
When I did my training in South Africa, I went out with Fight for Sight, and they removed cataracts within indigenous communities within the bush. And so we'd arrive at the hospital and there'd be rows and rows and rows and rows of people all queuing up to have their cataracts done. So those who were waiting to have the operation and those who were coming to have to get their glasses afterwards, because they wouldn't put a lens implant in. And I think we observed the operation and they got it down to taking those cataracts out in 4 minutes. But it was quite something. But once it was out and they were given like the glasses because they with the lenses externally, it was like, oh, it was hallelujah.
And the difference fantastic. There in a place like Africa is the difference between a father trying to feed his kids and he's a fisherman and he can't actually repair his nets. You do a cataract operation, gives him the glasses, and suddenly he can do his work.
Again. Oh yeah.
So there it's quite profound the benefit of doing it, and it's a shame that we don't do more of it because it is something that should be done. But it's a bit different in the UK. We'll bring ourselves back to the UK.
So because obviously they don't have the benefit of having diagnostic medicine at a drop of the hat like we do, fortunately, even if the waiting lists are a bit skew with at the minute, to say the least. So, Nikki, can I just talk to you, because you did work in diagnostic imagery, didn't you, before?
Yeah.
So, can you just walk us through the process of getting cataracts identified?
Yeah, so for lots of people it will be identified at their optician appointment, or it might be that they're coming to hospital for some treatment for something else in the eye, and it will be picked up at that point. But you're right, technology is, plays a really, really big part in ophthalmology, and in particular with OCT, optical coherence tomography, although it's looking at the back of the eye, actually it's the probably first point at which we can decide how maybe advanced the cataract might be, because actually if it is quite an advanced cataract and it's matured, it's really difficult to then get that scan. And what most doctors will want to do is check the back of the eye before they decide to go ahead with some procedures, because if they can't see what's going on at the back, it could be a risk factor. So if we struggle to get that OCT image, it might be then that a person is then referred to have an ultrasound, so that can pick up whether there's any kind of issues in the retina, detachments or tears that need to be sort of treated first, and it will just help kind of aid that decision. Lots of patients are quite surprised when they get used to OCT because it's become so common in eye clinics, but when they're then told they have to have an ultrasound, that can be a little bit of a shock, because it's like, why do I now need this? And it's quite an invasive procedure as well, in the sense that it is physical contact on the eye or eyelid. So it's a probe. We usually use a little bit of cold gel, and it's rubbed over the eyelid or eyeball depending on the procedure. But it can be something that patients just aren't prepared for, and they think that it's something additional, something else might be wrong. So it's really important that people understand that, the clinicians will be making that decision and making that referral for that additional testing, just to double check that there's nothing else going on before they make a decision about going ahead with the cataract procedure.
So the other thing that sometimes happens, and that people have come and report to us in the clinic, is that they're all ready to go and have their cataracts done, so they go there and then they're told they can't have them done for whatever reason. It might be in high blood pressure. Nikki, you've worked in that service. Do you want to expand on that a bit for us?
Yeah, sure. So as part of the process, patients are usually brought in either on the same day or at a separate appointment to what's called a pre-op appointment. And that's where, a specialist nurse or a staff nurse will kind of go through a lot of the patient's history with regard to other illnesses, other conditions that might cause an issue with this particular procedure. So they might be checking things like blood pressure, heart, is the patient on any blood thinners? These are all things that sort of the doctor will need to take into consideration. Usually at that appointment as well, the patient would have what's called a biometry, which is very similar to an OCT scan, which I talked about before, but its primary purpose is to calculate the power of the lens that's needed for that sort of what we call an intraocular lens, the false lens that's going to replace the lens that's originally in the eye. What can happen at that appointment is something might come up with the patient's history to do with other health conditions that might mean that they're not suitable. It might be that they're not able to lay flat, which is the preferred way, but it might be that there's other ways they can work around that. So it doesn't necessarily mean that they can't have the operation, but it just might mean that they have to adapt the way that they do the procedure. Or it might be that blood pressure is too high, and therefore they might need to postpone until they get that under control, or other things under control. Sometimes with the biometry readings as well, that can be quite tricky. Sometimes the machine isn't able to get the calculations, and so they have to use other ways to calculate the power of the lens that's needed. So there's lots that can go on in that pre-op assessment before somebody can be cleared to have the procedure. I'm certainly no expert on that. I didn't used to do those clinics, but from what I understand from my experience,
So it's quite an important.
it's an important part of the process. Yeah.
Yeah. Thanks.
Okay, yeah. So talking about the cataract procedure as well, Gary, can you talk a little bit about the surgery and what's involved with the actual surgery itself?
Yeah, so usually when if you're being referred for a cataract, the first appointment at the eye department, in Doncaster we do have a couple of private companies that do NHS work, so it's a little bit different, but we do refer people to the eye department of the hospital as well. So if it's just a straightforward cataract referral, the first appointment is to just assess that what the optician said you have is what you actually have, and there's nothing else going on. So they would do this OCT that Nick has just talked about. They would probably do a what we call a wide field, which is actually to take a photograph of the sort of 90 degrees further out that we could ever do that in the opticians. That just makes sure that the eyes are healthy and that everything's okay. They would talk you through the cataract, the benefits and risks of surgery or a procedure. They have to do that because you have to be informed about what could go wrong. And when I do refer people, I do mention that will come up, so not to kind of panic when they start saying that 1 in 10,000 do get eye infections and potentially the vision is worse, because you take the other side of it, that means that most of the time it does go right. It's just that they have to tell you about things that won't go right. So that appointment's not to do the surgery, and probably would last probably about an hour. Once you actually are then offered the cataract surgery and procedure, they'll ask you to sign some forms just to say that you're informed about what they're going to do, and then they arrange another appointment, which is actually for the surgery itself. So depending on where it is, so for instance, if it's in a hospital, what tends to happen is that you'll be invited in quite early doors, kind of maybe 7:30, 8 o'clock sometimes. And the reason they do that, they might have 12 or so people that they're going to do that morning, and they want to make sure everybody arrives. And if they don't, then they don't want you hanging around for an hour. And you'll have your prepped sort of the blood pressure. They'd also have make sure there's nothing happening in your eyes, no infections. The procedure then, once you're actually going to the theatre, obviously it's sterile. The surgeon will ask you to lay on a table. It's quite a flat table. They'll cover the eye that they're not going to do the procedure on. They put eye drops in several times. They occasionally sting a little bit, but only for about 20 seconds. And those drops are one to numb the eye so that you can't feel it, and the second one is to make your pupils bigger so they can actually see the lens that they're going to work on. They then actually make a very tiny incision. I'm holding a pen which is of no use to show you, but the tip of the pen, if you think about the tip of a ballpoint pen, is about as big as they actually make an incision into the eye. You don't feel it, and it's actually the outer edge of the cornea, so you don't even kind of see it. People do report that because of the hands of the surgeons over the top of you, then they can see things moving. They might see colours and also feel kind of pressure as they're just pressing and pushing. But other than that, it's nice and straightforward. They then break down your lens. They use an ultrasound, quite a high frequency, which actually breaks that down. They remove that in little parts. The lens that goes back in essence, again, if I could show you, it'd be easier. If you imagine a pen, a ballpoint pen, and inside it has got a folded umbrella, which is actually what the lens looks like when it's folded. They then place that back into that little opening that they made for you. There's a little wire that's on it, and they just gently pull that, which opens up the umbrella, which is the lens, and that opens up inside your eye. So this is why these days the incision that they make is really small. They very rarely do use stitching, because the way that they actually make the opening, it self-seals. And once that lens in place, they just rearrange it to get in place. Then once that's done, they will give you a patch to wear over the eye, which is usually for about 24 hours, and you're also given some eye drops. They're usually steroids and antibacterial drops as well, and that will help stave off any infections. Usually is quite intensively for about a month, and then they ask you at that about a month stage to go back to the optician, and they're going to make sure that everything that they did went well. And that kind of is, in a nutshell, what it's all about.
Can I ask a question
You
then?
can.
So that lens that they put in the eye, that takes up the distance prescription, is that right?
Generally, yeah. In the NHS, they only provide a distance prescription. Occasionally, if you have, I say odd eyes, but if you're really
Like
short
my
sighted, I'm looking at it now.
I've got odd eyes.
You've got odd eyes. But if, say, you've got one eye that's really long sighted and one that's short sighted, they would try and maybe balance it. Or if you have a job that requires a linear, they might just alter the prescription a little bit. But the surgeon's job is to give you the best distance vision possible. That's what they look to do. So yeah, distance. Sometimes you get people coming back saying, they told me I wouldn't need glasses, and then we said, but you do. That's simply because when the healing occurs, they try to use the lens that will make it back to zero, so you don't need glasses for distance. But sometimes Mother Nature just distorts things a little bit, and you end up kind of needing a top up on the glasses for your distance. And also we do get a lot of people where they've had varifocals for best part of 30 years, and it's part of them, and they actually want varifocals for convenience. So the top part of that varifocal might be negligible, no prescription, it's just to help with the reading side of it.
But you would need reading glasses.
But you would generally need reading glasses, if everything goes well. There are bifocal and varifocal implants that they can do, but none of that's available on the NHS. They are a bit more complex, they are quite a bit more expensive, and sometimes we find that people still need kind of readers to top up the sharing of the vision, because you've got a distance and a reading in the same eyes, so you're only giving 50% of reading. So sometimes people, if they are reading intensely, do need kind of reading glasses, but that's not available in the NHS in the UK.
Okay.
Okay, so we've kind of touched on stuff that people can do to help with cataracts, but is there anything long term that people can do, Anita, for if the surgery is not available or open to them?
I think it's kind of part of the aging process, isn't it? It's a bit like wrinkles. We're all going to get them if we live long enough, I think. But just generally for eye health, just following a good diet, lots of leafy green vegetables, broccoli, spinach, kale. That's always good for the eyes. That's got that lutein and zeaxanthin that we need. Wearing decent sunglasses, not smoking. All the usual kind of sensible health advice. But definitely the leafy greens are indicated in good, the nutrients that we need for the eyes. So yeah, kale, spinach, broccoli, all those veg that most people don't like to eat.
Yeah, and Gary, how often should people have their eyes checked? Just as a routine.
As a routine, we said every 2 years. We were asked recently. We did a presentation to an IT company recently, and that question kind of came up, because someone also asked, are there any times where you don't notice or you don't have symptoms of eye problems? And I kind of went, yes and no. The reason I meant that was because with a cataract, it's such a gradual thing that you assume that what you're seeing is what everybody else is seeing. And if you just sit and wait, just think about that for a second or two. Is an orange colour to you, or as what I think an orange is orange. So we actually always assume that what you see is what I see. And it's only sometimes where you get to that point where you go out and somebody says, "Oh, look at that over there," and you go, "I thought that was a fellow rather than a lady," kind of thing. And that's when you realise. So the idea of a regular eye test every 2 years would be just to do the measurement of that vision, and that's a Snellen chart that we use as normal. If you've had an eye test, you will know. But also it looks for any of the other signs of problems like macular degeneration, which we'll talk about. We have talked about. So that. Every 2 years is useful. There are some criteria where it might be less than that. So if your optician thinks that you're developing problems with the cataract quite quickly, or it's in one eye more than the other, they might invite you back every 12 months or as what they feel is necessary. But everybody is about 2 years. So I think that's a good principle to have.
So I know a lot of people come to me and say, I've been told I've got cataracts, but they won't operate on them until they're ripe.
I don't particularly like that as a saying. It's not ripe. Ooh, yeah.
Sounds like a piece of fruit, doesn't it?
Think about a ripe fruit, it's all squidgy.
What if it's overripe or a bit moldy?
It does.
It waits a bit longer till it's overripe. And in fact, leaving it far too long actually means that the consultant then has a harder time at removing that lens. So I don't particularly like the word ripe, because to me, if you think about ripe strawberry, it's all squidgy. And that's not what I want you to be taking out. But yeah, so I think also it used to be where they would wait until it had to be. In the UK, they're kind of level generally across the UK, and every area has a bit of a difference of opinion. But generally, if you are at the point where you should be told that you shouldn't be driving, which is 6/12 on a Snellen chart, that's also usually the point where the NHS would say, yep, they'll fund that cataract operation. So it's kind of one of those, I'm telling you shouldn't be driving, but the good news is that it's the cataract that's causing you problems. So by having that done, that would actually help out, yeah.
So normal vision is 6/6.
6/6, which if you think of a fraction, that's 6/6 is 1. 1 is normal vision. 6/12 actually is half, isn't it? So yeah, you have to wait a little bit. And the reason that also is that if you have 20/20 vision or 6/6, as we've mentioned, if we talk about those risks that are involved, there is a potential that you end up with a little bit less vision than you started with. Whereas if you're 6/12, potentially and statistically, it's always going to be better.
Make it better.
So yeah, so it might still not be 20/20. But you might have a lazy eye, as we call it, or amblyopic eye. You're never going to get 20/20 vision with that eye, but it would improve it. So you're not going to do it automatically. You may, again, if you Google this, you'll hear of lens implants. That's a little bit different, because lens implants are where you've chosen to have those lenses removed, and it might be that you don't have a cataract, but they would talk to you about the risks of removing something and putting something in. And usually in that scenario, it's usually where they're talking about varifocals and bifocal lenses. I mean, because you want not to have to wear glasses. That's usually that. Yeah.
So if you've got one eye that's worse than the other,
Yeah.
and you've got cataracts on both eye, which eye would they look at doing first?
Ooh, again, I'm going to have to go. It depends. So we generally have a dominant eye. So if you're right-handed, usually it's your right eye. So let's say your right eye is the worst one, then that's kind of easy, because if your dominant eye is the worst one. If you right-handed right eye, but your left eye is the worst one, that might cause a few problems, because if you make your vision better in the left eye, the brain's going to start fighting with the other one.
So then what, you get double vision? And
yeah, you could end up with a few problems. But that's something that, again, in Doncaster, where we do the referral, we're asked about the dominant eye, so we're asked to measure with that one, and also which eye we think that should be done. But at the end of the day, it's the consultant and you as a patient to talk about it. And we have had a few problems where they've done the eye that they hadn't realised the eye was a lazy eye, done that one, and there's not been a benefit, because the other eye is the one that you use most.
So that's when people come to us and say that it hasn't worked.
It hasn't worked,
the surgeon's messed up my eye, when it's actually kind of not always the case, is it? Or like Nikki said, it might be the fact that there's something else going on behind the back of that eye.
Yeah, so if you've got, and that's why they would do, as Nikki was saying about doing the ultrasound. So if you think about the eye as a camera, which often we talk about, the lens we're removing, which is the camera lens. So we've put a brand new clean lens in, but the film at the back of your eye is a bit wrinkly, which is actually the equivalent of macular degeneration. They're not replacing that. So the benefit will be the clarity of the cataract removed, but you've still got the underlying problem. So that would be where you wouldn't possibly not get as good result as you maybe expect. But again, usually that's talked through at that consultation, that first appointment to the hospital, to give you the sort of this is what might happen, or this is what will happen. So it's always helpful to talk through that.
Absolutely. I just massively from a mental health perspective, I think it's managing those expectations.
Yeah, expectations.
Good
and
call, just sort of making sure that people are aware of what they can expect from it. What sort of side effects they'll get from it, how good the vision's expected to be, and why it might not be what they hoped.
Yeah, expectations, good word. Yeah, good word actually in that one,
So the other question, sorry, I'm just, as we're sitting here, they all keep popping into my head. So sometimes what happens as well is we'll see people in the clinic, they've had the cataracts done, they've not going back because they can't go back, but they'll come and the vision will have dropped, and so you'll advise them you'll refer them back in to have some laser treatment. Do you want to explain why that is, Gary?
Yeah, so sometimes people will come back saying, I think I've got my cataract coming back, which can't happen because it's an artificial lens they've put in there. But where the lens is sitting, there are two chambers, there's the front and the back, and the rear chamber is the bit that has all the gel in. And there is a little sac that sits behind your lens that stops that lens from falling backwards. And we're not really sure. It happens in about 10% of the cases, and they've done all sorts of different changes to lenses, profiles and materials to see if it works. But in about 10% of the cases, the lens, the sac at the back gets rubbed a little bit. And if I kind of say it's like having a callus develops, because where you're rubbing the feet, you'll get a callus. So it's kind of similar in the eye. You get this callus effect, which then actually gets cloudy, so it's like getting your cataract back, which is actually really easy to do because we just refer you back in. It's actually called posterior capsular opacification, which is big long words.
Right.
It just means that little sack's gone a bit cloudy. And the trick to that is when we send you back, they will do what they call YAG laser. So again, laser sounds like a burning, but it's much easier than that. And in fact, the procedure takes about 90 seconds, and it takes longer to get your name and address off you. You don't even get a cup of tea with them.
Yeah, I remember taking my dad for it as well. It was like we all sat outside thinking, oh, it's going to be a while. And he was in and out. It was like, is that it? You know, it's done.
And it's not invasive. They don't have to go into your eye like they would have done with cataract. So from a point of view of trauma to you, it's about 10% compared to having your cataract done. So if you've been through having a cataract done maybe twice, then having YAG surgery procedure is actually nice and straightforward. And you're going to go, have you done? And the results are instant because they've actually blasted a little hole through, so you've got that vision back again. And that doesn't alter your prescription very much either. So you know what you've already got would actually work. So yeah. So
quick fix.
Yeah, quick fix.
Yeah, I think it's about just letting the cataract have that time in between to settle down. You know, I think some people expect those instant results because they hear it from a friend or, you know, but actually if it is, as you say, Gary, that condition that's kind of from that sac that's come back, then it's, you've just got to have that time, haven't you, in between.
And I think the average time between cataract surgery and the posterior capsular occurring is very rarely less than 12 months, but very rarely more than 3 years. So it usually happens within that period, and it is 10% of the time, so it's not going to happen to you if you had a cataract on, and it is a doddle to remedy. In fact, most of the clinics these days have got the machines kind of set up, so it's even just we know what it is, let's sit there, let's have a look, yep, fine, click, click, and it's done. So you're not having to kind of go backwards to resolve it. It is fairly straightforward. And it is actually quite profound how it affects the vision. But yeah, it's not a cataract coming back, so if you had them done, they won't come back.
Brilliant. Well, I think that's a good place to jump off. I think we've done quite a long one this month, haven't we? So
I go for a nanny nap now.
You've got a whole day at work left.
Oh my God.
I just want to say thank you to Anita, to Nikki and Gary again for joining us.
No
and
problem.
if you've got any questions or if you've got any concerns about anything you've heard in today's episode, at the Partially Sighted Society we are here to help. So you can find more information about our services on our website. That's www.partsight.org.uk, or you can even give us a call. I might answer, or it might be Marcus or Andre, one of the team here anyway. So that's you can give us a call on 01302 965 195. Thank you very much again for listening. The information provided in this podcast is intended for general knowledge and informational purposes only, and does not constitute medical advice. The content is not a substitute for professional medical care, diagnosis or treatment. Always seek the advice of your ophthalmologist or other qualified healthcare provider with any questions you may have regarding a medical condition. Do not disregard professional medical advice or delay in seeking treatment because of something you have heard on this podcast. The Partially Sighted Society does not endorse any specific tests, treatment or procedures, and information provided on this podcast should not be considered as such.